Hey there, and welcome back. For those of you that don't know, my name is John. I'm a patient with type 1 diabetes for the past 45 years. I currently work as an ER doc in New Hampshire, and I spent about 15 years of my life running a diabetes center in northern New York. These videos were started about 3 months ago to provide some diabetes education, open up diabetes awareness, enhance knowledge, share stories, make folks laugh, and have a good time. None of this is ideal medical advice. All of your medical advice and changes to your own care should come through your provider or at least be discussed with your provider. So please don't take this as directives from a physician on changes you should make. We've had a lot of fun here talking about a lot of type 1 diabetes, a little bit of type 2 diabetes. We talked about diabetic alert dogs, diabetes camps, college with diabetes, high school with diabetes. We even interviewed my mother to get her input, which I highly recommend folks watch if they are dealing with a family member with any form of diabetes. It's always interesting to see the other side. Today, I thought we would dive a little bit more into type 2 because that's a very large topic, a very complicated topic, and we could spend the rest of the year on it. What I'd like to go over today is some of the big medications, the more popular medications in type 2 diabetes. We're going to talk about GLP-1. GLP-1 is a glucagon-like peptide, an incretin hormone. Okay, so it's technically glucagon-like peptide 1. This is an incretin hormone in the body. This hormone is produced in cells called the L cells at the far end of the small intestine. So let's take a patient without diabetes. A patient goes to McDonald's, they have a Big Mac and a Coke. The second they start eating and swallowing, there's some messengers, we'll call them messengers, little molecules that go down into the GI tract and kind of tell everybody what's going on. This is how a lot of these patients are able to produce the appropriate amount of insulin right away. More importantly, these messengers, little hormone messengers, go to the small intestine and get to the end towards the large intestine and tell the L cells, hey, there's a lot of glucose coming down. This is McDonald's. There's a lot of fat coming down. So what these cells produce is GLP-1 and GIP. We're going to focus on GLP-1, the glucagon-like peptide. This is where your medications such as Victoza, Bydureon, Trulicity, semaglutide, all of these are based on this physiology. So the L cells in the small intestine are told about the food coming down the track. They dump out a bunch of GLP-1. GLP-1 has a few jobs. First thing it likes to do is go over to the pancreas. The pancreas sits behind the stomach, has beta cells in it, in an area called the islets of Langerhans, and these beta cells produce insulin, one of my favorite medications. So the GLP-1 says to the beta cells, hey, this is what's coming down the road, this is what we need to do. So the beta cells will then respond by producing an appropriate amount of insulin. They've started doing this on their own. This is sort of a safeguard and a guide. On top of that, they help us form our feelings of satiety. They help our sensitivity to the insulin. They work in what's called the biofeedback or the response to insulin to calm the liver down. In other words, it says to the liver, hey, you're not starving. We don't need to release stored sugar. Slow down. Let the pancreas get this new food that's coming into the bloodstream with insulin so that it can get into the cells for energy. So that's how a patient without diabetes functions. Now, keep in mind, I'm talking type 2 diabetes here. Type 1s are boring. We're pretty black and white. We just don't make insulin. So in the type 2 patients, this ability is blunted. So they often do make plenty of GLP-1. Oftentimes it's a little bit low, but all of the time it does not work very well. And it appears to be that the beta cells just don't listen to them very well. So without that, they will have a higher blood glucose level, a higher A1C. Remember, that's the 3-month average of blood glucose. They will have to urinate more. They will be thirsty. They will have to push more water through the system to get the glucose out. Their energy levels are down. They're going to be eating more. And their balance between the liver and the pancreas, with the insulin and the glucagon helping to keep those levels balanced, is not as effective. So we get high glucose, we get a hungry patient with no energy, who's fatigued, who's not exercising, we get weight gain, and we go down this dark path, the path that we talked about before, about building resistance to insulin and eventually getting to the point where we can't make enough insulin to keep the sugars where we need them. The laboratory cutoff is hit, and boom, you have diabetes. So this is a fairly new, and by new I mean about 20 years, finding in diabetes. And some pharmaceutical companies have found a way to make this into a therapeutic method. So there's two classes of medications that function on this ideology. One are the DPP4 inhibitors. Not that you need to know it, but just for giggles, dipeptylpeptidase 4 inhibitors. Well, what is dipeptylpeptidase? If you remember your biology classes back in grade school and high school, any word that ends in ACE is what we call an enzyme. So it's a tiny protein that is designed to break things down. So we have amylase, we have all kinds of different ACEs throughout the digestive system to break down things. We also have those on our own for chemicals we produce. So what goes on with the dipeptylpeptidase is after the L cells release the GLP-1 has done its job, the dipeptylpeptidase is released and it breaks down the GLP-1. And that's how balance is maintained. The human body loves balance, or what we call homeostasis. We want everything to be balanced. So the dipeptylpeptidase 4, we'll call them DPP4 inhibitors, are medications like Januvia, Tradjenta. Am I lying to you? I might be lying to you. Forget the Tradjenta one, sorry, it's been a while. Januvia was the big one that came out. And what these do is they block that enzyme from breaking down. These are the gliptin medications. I don't know how many are still out and really popular, but saxagliptin, linagliptin, there are a bunch of gliptin medications that were DPP4 inhibitors. So you take the pill, it's an easy once-a-day pill, goes into the system, and it blocks the dipeptylpeptidase enzyme from working. So now you have more of your naturally made GLP-1 around to help you make insulin when you need it. That's key because we don't want to cause a low sugar. It's neutral on weight. It doesn't cause you to gain weight. It doesn't cause low blood sugars because, again, we're making insulin in response to need. And they really have no impact on the heart. Of about 15 years ago with diabetes medications, the FDA, who approves these medications, became very focused on no weight gain, no low sugars, and heart healthy. So a lot of the medications that we still use in type 2 diabetes care don't have those three marks, and they can be risky for patients. So why do we care? Nobody wants a low blood sugar. Even us type 1s don't want a low blood sugar. But imagine you're 75 years old, you live alone, and you have a low blood sugar at the top of your cellar stairs. Or you have a low blood sugar driving a car. Big difference than if you're 20 and you're sleeping till noon and have a low blood sugar. Heart healthy is pretty obvious. Cardiovascular risk doubles with diabetes as it is. We don't want to add any more fuel to that fire. And then the weight gain goes back to insulin resistance and cardiovascular health. So these are the things that they really want new medications to focus on. And Januvia had no problems with these. We saw a mild to moderate improvement in blood glucose levels. The A1C would come down. Never saw any weight gain with it. Really no side effects. People tolerated it very well. It's a once-a-day pill, so it was easy to take. So that was pretty popular for a while. And then some other pharmaceutical companies went a step further. They said, well, wait a minute. Instead of blocking the cleanup of naturally occurring GLP-1, why don't we just inject GLP-1? So this came out with your Victoza, Byetta, were the first couple ones out there. And these were daily injections of GLP-1. So now what happens is you get a pharmacological load of GLP-1, a lot more than what you normally have. It goes to the beta cells. It tells them to produce insulin appropriately. So the beta cells will produce it in response to blood sugar, in response to eating, as opposed to random dump of insulin. It will also affect the balance between the liver and the pancreas as far as glucagon is concerned. So you get improved blood glucose levels there. It impacts how fast food goes through the stomach. And this is a key factor, especially for anyone taking this medication. Food will go through the stomach slower. The result is the patient feels full sooner. This is a good thing because the patient, instead of having 2 Big Macs, might only eat half a Big Mac. This is a big thing because one of the most common side effects of this medication is nausea and vomiting. I believe this occurs because people don't listen to their body. You start to feel full, you need to take a break. Get up from the table, get off the couch, walk around, and give it some time. You may find that you're no longer hungry, and you're happy with what little bit you ate. Add to that, the GLP-1s also work up in the head to reduce your appetite. So where you used to sit down to watch your favorite TV show with a bag of popcorn and some peanut butter crackers, you may find that 1 or 2 bites and just not interested. So this has a very positive effect on the demand we place on the beta cells as far as keeping the blood sugars low. Keeping them normal. So what happens is I'm less hungry, I get full sooner, so I'm taking in fewer carbohydrates. I have the GLP-1, the pharmacological load of the GLP-1, telling my pancreas and my beta cells to produce the appropriate amount of insulin when necessary, so I don't get low sugars. I have improved balance between the liver and the pancreas. And next thing you know, my blood sugars are improving dramatically. We see a very good blood glucose level improvement. We see a very good reduction in hemoglobin A1C with these medications. We also see weight loss. The patient's not eating as much. They're not hungry as much. Or when they serve a meal, they're not going back for 3rd or 4th helpings because they're just full. So weight loss equals, if you remember last week's discussion on type 2 diabetes, more insulin sensitivity. Weight is directly tied to resistance to insulin and how well the little bit amount of insulin you make will work. So this is a wonderful medication because we have the opportunity to improve sensitivity to insulin, improve the ability to produce insulin appropriately, reduce intake, reduce carbohydrate load, and maintain balance of the liver and the pancreas. The positive effect of all of this is heart health. A lot of these medications have demonstrated heart health, so improved cardiovascular health. None of them show detriment to the heart. Some of them have even shown some help. Side effects, nausea and vomiting and GI side effects are the biggest one. And in my experience, this was because people would not pay attention to being full and would try to eat through it. Elderly folks that have experience in times of the end of the depression, depending on their age, or times when the family wasn't doing as well, you clear the plate. You have to clear the plate. We've all been through this. Our grandmother tells us to clear our plate. If we don't clear our plate, somebody else will clear it. And this mentality leads to a lot of complex carbohydrates we don't need, a lot of work for the pancreas that a type 2 patient can't handle. But when we eat through that feeling of satiety, that feeling of fullness from the medications, we get nauseous, we feel horrible, we often vomit. When we listen to it, say, I'm just going to eat half the plate for right now. Let me take a break. Maybe I'll come back in a half hour. We do much better. Number 1, patients rarely come back. And number 2, they feel better. So we get weight loss, cardiovascular protection, if not neutrality, improved blood glucose, better balance between the liver and the pancreas, better insulin sensitivity. We address a whole bunch of areas where type 2 diabetes impacts us. Patients do very, very well. So it's a wonderful medication. They have advanced. The pharmaceutical companies have made these into once weekly injections. That would be the most popular ones would be your Trulicity and your Ozempic. They work wonderfully. The other side of the fence is they've added weight loss as an indication, kind of separate from the diabetes. So some insurance companies are covering medications like this or even stronger ones to help people lose weight. And that's a whole nother discussion, but you can see how these impacts are very positive for weight loss and insulin sensitivity and folks that may have the opportunity to avoid the diabetes label. So very powerful medications, very positive medications. Yes, they're an injection. Let me tell you, it's a 32 gauge needle. It's a tiny pen needle. It's once a week. Pretty simple. I will tell you, for those of you using or thinking about using Ozempic or Victoza, I did a lot of work with these medications. I had a lot of folks on them. Sometimes as you bump up the dose, people have a tolerance issue. For instance, they do fine at the lower dose. When they go up to the higher dose, they feel bad. They feel nausea and whatnot. A lot of times that's just the big jump. All of the flex pens, which is the technology that Novo Nordisk uses in their pens, click. And the click is more volume. So if you look at the Ozempic pen, you'll see the low dose, and then you click up, I think, like 17 times to the next dose, and so on to the third dose. So you don't have to make that 17 click jump all at once. I've had many patients do very well with a little bit slower progression to the higher dose, and they avoid the side effects. So those are two big type 2 diabetes medications that have become extremely popular in recent days. They're great medications. I had a great time using them. I had a lot of success with them. Was not as big a fan of the DPP4 inhibitors, the pills, just because it's a minimal impact. And like we talked about, the type 2 patient isn't as sensitive to their own GLP-1, so it doesn't work as well. So getting that pharmacological load from the injectables, the GLP-1 agonist, the patient does much better. Side effects are manageable. Watch how much you eat. Be careful how you eat. Eat slowly. I'd rather see small, frequent meals than one large meal because you will not tolerate it well and you will not be happy. Revel in the feeling of satiety, the central action GLP-1 agonists. When you inject them and you open the cupboard door thinking, what do I want for a snack? And you can't figure it out. That's a good sign. Go with that feeling because you might not need anything to eat. So use these, kind of work with the medication. You'll find you get a much better effect. I'm sure we'll see more to come on these GLP-1s, the GIPs, and even the glucagon balance, because despite the fact that I believe insulin is the god of all hormones and involved in just about everything, I think we're going to see some other hormones start to come into the picture and show us some other therapy modalities. So that's my bit on GLP-1s and DPP4 inhibitors. Please post any questions into the comments. I'd love to discuss more with you. I think next week we'll probably tackle some of the standard medications. I know these aren't as exciting for my type 1 patients, and people often ask me, can a type 1 go on Victoza or Ozempic? Absolutely. If the insurance company will cover it, and 9 times out of 10 they will because diabetes is so common, they don't bother to differentiate between type 1 and type 2. So if you can get it through the coverage, you can certainly get it covered. Now, what will it do for you? It's not going to help a type 1 patient produce insulin because we don't produce insulin. However, the full sensation eating, the slowed stomach motility, how that part of it works, getting full early in the meal, definitely takes effect. I've taken this medication myself. And the satiety in the brain. So working in the brain, making you less hungry, less likely to snack, absolutely takes effect. Weight loss is definitely there. Those that have the cardiovascular benefits, you're certainly going to see some of that. You just won't see as dramatic an improvement in blood sugars from insulin production because we don't produce insulin, but you'll see an improvement with the amount you're eating. So if you do talk to your provider, decide you want to try something like this, word of caution, if you're not on a sensor, this becomes more difficult, so you need to blood test more frequently. If you're taking multiple daily doses, be careful. You might want to dose after your meal. So use one of your fastest acting insulins and dose after your meal because you may walk into that meal thinking, I'm going to eat this huge plate, and you only eat a half of the plate. So you don't want to cause a hypoglycemic event. I learned that one the hard way. And the last thing you want is a hypoglycemic event when you're full. A low blood sugars are fine when you're hungry. Give me a bowl of ice cream, give me that food that I rarely can eat because it raises my blood sugar. That's fine. When you're not hungry, it's just annoying. But what I did find very helpful with these medications as a type 1 is when I have a low blood sugar, there's not enough food around. I have a hard time stopping myself saying, okay, I had 15 grams of carbohydrates. Let's give it a few minutes. There's fear, there's anxiety, there's hunger, and I go crazy. When I'm on these medications, that's almost eliminated. I can easily take a slug of maple syrup. Say, okay, that's about 15 grams of carbs. I'll wait a little bit. I'll be okay. It's not the slug of maple syrup, the spoonful of peanut butter, the piece of toast. Sometimes I can go crazy. And, I'm human, just like all of us. We make mistakes. But this medication is very helpful for type 1 patients in that manner. Whether it's worth an injection a week, that's up to you. But certainly, if that's something you as a type 1 are thinking about, then I highly encourage you to discuss that with your providers. So again, let me know any questions you have in the comments. If you like these videos, please throw us a like. If you want to see more of them, subscribe to the channel. There's a whole bunch prior to this, and there'll be a whole bunch more coming. Please share your thoughts, your concerns, any subjects you'd like to see, and we will definitely hash them out over time. Bear with me. I work about 3 jobs, and sometimes I'm a little sluggish getting this part done, but I appreciate all of your comments. I appreciate all of your support. And most importantly to everybody, stay healthy.